This is on transvenous pacemaker insertion. So indications for a temporary pacer: bradyarrhythmias, AV conduction blocks, trauma, typically see here, permanent pacemaker malfunction, drugs, electrolyte imbalances, or sick sinus syndrome. And likely the list isn't exhaustive, but some good examples of why we might be putting in a temporary pacemaker. Gathering your equipment. So you will need a pacemaker insertion kit, so the Arrow pacemaker insertion kit, which is a bipolar balloon, pulse generator, new battery, the thing that's most commonly forgotten, and connecting cable that will connect the leads to the pulse generator. Smart idea to insert the battery, turn on the unit, and ensure that you're seeing where it says pace, that you're seeing a green flash, knowing that your unit will be ready and hooked up to the pacing wires. The doctors will access, for pacer insertion, will insert a central line. Typically they will pick an internal jugular, usually trying to stay away from the subclavian because that will be a site often used to insert a permanent pacemaker, but if they need to, they will use whatever site is indicated. Insertion of the cordis. And so we'll open up the kit. So the kit is a two-part kit. It has both the central venous line insertion portion and the pacing wire. So the pacing wire, this kit has been used previously as for teaching, but you'll see the pacing wire will be packaged separately. You'll set that aside, and then you'll have the contents to initially insert the cordis. Things to prepare as a nurse for insertion of the cordis will be a flushing solution for the doctor to flush the side arm and cordis prior to insertion, and pre-primed IV solution, whether it's D5W or normal saline. Once the cordis is inserted, you will attach the running IV so that it's running prior to them inserting the pacing wire through the cordis. Unique to this cordis for pacemaker insertion is the 2E Borst cap. It's a cap that actually locks on to the top of the cordis and has a thread for the contamination shield to lock onto once the pacing wire is in situ. So that the doctor will actually attach that cap once the cordis is inserted, preparing for the pacing wire to be advanced. The pacing wire, once the cordis is in place, the pacing wire will then be prepared for insertion. So a few things that they'll check first as I unwind this will be that the balloon is intact at the end of the pacing wire. There's a specialized syringe in the kit that holds 1.5 mils of air. They will attach it and they will inflate the balloon to ensure that it inflates appropriately. Removing the syringe to ensure full expelling of the air in the balloon. I can have the syringe attached. So once they're happy with that, what they will do is take their contamination shield, feed the wire through the contamination shield, preparing to insert into the cordis. The contamination shield will stay collapsed until capture is obtained. And ensuring that you've fed the end appropriately so that you have the locking portion that will fit over top the 2E Borst cap. Note that the pacing wire has markings on it indicating 10 centimeters, so 10 centimeters, 20 centimeters, 30 centimeters, 40 centimeters, so they know where they're at. When they feed as they feed the wire through the cordis, they'll continue feeding it through, typically until the 30 centimeter mark, They then are most often, for most patients, located in the right atrium. At that time, what they will do is inflate the balloon, lock the gate clamp there so that the balloon stays inflated, and they will continue floating the catheter. Position of the catheter will float with the blood flow into the right ventricle. While it's entering the right ventricle, they will start watching the monitor, because, just backing up, when they inflate the balloon at the 30 centimeter mark and they're in the right atrium, at that point they will hand the nurse who's assisting the leads to attach to the pulse generator. You're going to be able to take the pulse generator extension cable and actually positive to negative and lock in the leads appropriately. You would just lock them in appropriately into the cable. The doctor will give you direction to what to have the pulse generator set at. Typically for insertion, you'll see a rate selected at 80. You'll see an MA set at usually 5, but it might be just slightly less, and sensitivity, the most sensitive, at 0.5. That way, as they're advancing the balloon into the ventricle, be the most easy to obtain capture. When they have the balloon into the right ventricle and they obtain capture on the monitor, which is an obvious pacer spike followed by a complex, that they are happy with the position, what they will then do is ensure their catheter is secured. They will lock down the pacing wire so that it stays in position. Typically, you're at 40 centimeters when they're in the right ventricle, so that's typically how far they have advanced the pacing wire into the line. One end of the contamination shield is secured over top of that specialized cap. Always secure that end first. It is then advanced all the way, ensuring you have advanced this all the way to the end. And you lock it in place at that end by turning it as well. And you'll see it cannot be pulled, it's locked into place. If the doctor has not already done so, they will ensure that the balloon is deflated. How they do that is they open up the gate so that it's in neutral alignment. They remove the syringe, and you'll see, because we have just the pacing wire tip sitting there, the balloon immediately deflates. You ensure the air is completely expelled from your syringe and reattach it to the balloon port. The importance of that is that if you left the balloon inflated, or even air in the syringe which could potentially enter the balloon can actually bob with the blood flow and actually move potentially into the pulmonary artery. So that's why you leave it like that. The syringe is attached with the gate in neutral position, so that if the balloon at any time potentially heats up and has some expansion, that the air would back off into the syringe. So part of your check will be to make sure the syringe is actually completely closed, or no air is in the syringe. So a couple things to make sure that it was done correctly as the nurse. One would be that they have advanced this contamination shield and that both ends are appropriately secured. Ensure your connection to your connecting cable is secured. Ensure the syringe on your balloon port is empty and connected, and that your gate is completely open. Ensure that you have an occlusive dressing in place over top of your central venous access. And the question is, you could use a regular IV advanced dressing, or you could use a CHG IV advanced dressing that has a small square chlorhexidine gel pad. Remembering that when you remove that dressing with the gel pad, to use something wet like a chlorhexidine swab, that as you get it wet with the swab, it will lift off the line. If you try and remove a CHG dressing without making it wet, it will may pull out your line. Important thing with the tubing here is that you want to very carefully loop your pacing wire tubing, and what is suggested is that you can sit it on top of a 4x4 gauze and gauze on top so that it's properly looped and covered, so that when you secure it or tape it down to the patient or wherever you're taping it to, that you don't put tape actually on the contamination shield. You want to avoid that. Inadvertently removing tape from that contamination shield can interrupt sterility. Ensure the patient is on bed rest. Ensure the pulse generator settings are protected by the face plate cover. And at this point, if a doctor hasn't already done so, they may readjust their settings. The settings used for insertion may not be the settings they leave the pulse generator on, so they may have a lower heart rate setting. The MA, which they may have inserted at 5 to ensure, easy visualization of capture, they can assess what the threshold is by backing down the MAs until they lose capture. And if that ends up, for example, being 3, then they will move it up again a little bit more just to ensure that you maintain capture. Some rule of thumb is doubling it. So if it was 2, they will put it up to 4. Sensitivity was set at the most sensitive at 0.5, meaning that the pulse generator is detecting any energy that the heart produces when it generates an impulse or a QRS complex. So they may back it off too until that they see where the sensitivity threshold is and then move it back up a bit. The important thing for nursing is to ensure you have documented what the doctor's ordered, the MA, sensitivity, and heart rate to be set up so that the next shift will know. If a telemetry pack is used at the same time to monitor a patient, you're to hang the pulse generator and telemetry pack on opposite side of the bed. An example of, to go back to the sensitivity, I'm just going to show you a good picture. So setting the fence is an example used to understand sensitivity. The sensitivity, like the fence is very high, you can't see the QRS complex. So that would correlate to the sensitivity number being dialed up very high on the pulse generator. As the dial is turned to a lower number, or the fence is being set at a lower height, you start seeing the QRS complex. The shorter the fence, the more sensitive the pulse generator is to assessing the patient's own intrinsic beat. And that is what the doctor will determine they need to set the sensitivity at. And that is it for the in-service.